Welcome to Health Literacy Out Loud. I'm Helen Osborne, President of Health Literacy Consulting, founder of Health Literacy Month, and author of the book Health Literacy from A to Z. I also produce and host this Health Literacy Out Loud podcast that focuses on many aspects of health communication, patient education, and health literacy. Today's guest is Dr. Jennifer Harvey, who is professor and chair of imaging sciences at the University of Rochester in New York. Prior to this, Jennifer was the professor of radiology at the University of Virginia Health System, where she led the division of breast imaging and the breast care program. Dr. Harvey served as the breast imaging section head for the American Institute of Radiologic Pathology and continues on its faculty. Among her many other accomplishments, Jennifer is a well-published researcher, lecturer, and journal editor. Her book, Making the Diagnosis, A Practical Approach to Breast Imaging, has been translated into 4 languages. Jennifer, welcome to Health Literacy Out Loud.
Thank you so much, Helen. I'm happy to be here.
Well, I think this is neat. You're probably the first radiologist I've interviewed for a podcast. Let's start from there. What does a radiologist do in breast care?
So we manage all of the imaging of the breast, whether it's men or women. We read those screening mammograms that hopefully all of you appropriately are getting. We also do breast ultrasound and read breast MRI. We also do procedures like biopsies for abnormal findings on imaging. Kind of everything up from, you got a screening or you have a lump through to when you're ready to go on to a breast surgeon or everything is fine and you can go back to screening.
It's quite the continuum there, and certainly I have a number of experiences too. I know your focus is often on bad news, and I really want to focus on that a lot. When there is bad news, what does bad news entail? Because you're talking about all the way from screening for someone who goes in feeling perfectly fine. It's a lovely day, nothing in my mind except I need my mammogram, all the way to someone who's getting ready for surgery. What do you mean by that term bad news?
You're so right, Helen. It's really starts when you have an abnormal screening. You get the news that we need to do other imaging, either mammogram pictures or ultrasound typically. And most people, it's kind of a knock on the door. There might be something there, but, about 70 or 80% of the time, those patients don't need to have a biopsy. So I get to go in and say, hey, everything's good. That's the best part of my day. And then, but if it's abnormal and they need a biopsy, as well as the biopsy shows cancer. So it's kind of that whole spectrum.
So I know I have more of a relationship with my primary care doctor. So I've been seeing her for a long, long time. And I go to her for when I'm sick or sometimes, in the routine visits when I'm well. I don't have an ongoing relationship with a radiologist. And I have been one of those people who did get the not good news. And I'm fine now. But it was a bit of a hump there. So what's the role of the radiologist who does not know that patient? What's your role in telling bad news? Or do you pass that on to the primary care doctor to do that?
It's going to depend on your radiology practice. Many of us who only do breast imaging, it's kind of like a clinic with imaging. We talk to most of our patients who are there with problems. It is interesting because this has been my practice really most of my career. And when I started really being sort of the primary breast doctor, that my primary care folks wanted me to talk with the patient because they don't necessarily have the same perspective for that person. They may not know that these are really suspicious findings or good chance this is going to be okay.
But they know the patient, but you don't know the patient. Can you tell us a story or an experience of when you were the one breaking that news to a patient?
Oh, well, I do it most days to tell somebody that they need to have a biopsy done. The most important thing is that perspective. So if it's sort of something that's suspicious, but not obviously going to be malignant, then the risk of that finding being cancer is about 20 to 25% of the time.
Mm-hmm.
So I try to put that into perspective for them. Also, if this is a small area, it looks like it would be early if there was something there. I really try to get that out in front of them, so that they're not losing sleep until we get the biopsy done and we get the results back. On the other hand, I've been doing this a long time, is that if I look at it and there's a very high likelihood that this is going to be cancer, that
Mm-hmm.
perspective is even more important. And you kind of got to like pace it a little bit.
Tell us about the pacing of that.
So if I look at the imaging and I'm like, this is going to be cancer every day of the week, my goal is I try to I call it a warning shot to put it out there that I'll say something like, this area is pretty concerning. And I just sort of let that settle a bit. And if the patient says, how suspicious is it, or how concerning do you think I have cancer? Then to me, they've given me permission to kind of go to that next step that, yes, I think this probably is going to show cancer, but I try to give them
So
whatever
you
good.
say a but.
Yes. So, let's say it's under 2 centimeters. That's considered early breast cancer.
Okay.
Sometimes it'll be the kind that's confined to the milk duct.
Mm-hmm.
You'll hear that called ductal carcinoma in situ, which just means inside.
Okay.
That is also very manageable. So I try to put back whatever good context I can for them.
I'm going to take a little bit of break there because I'm hearing my own stories in my brain as you're talking about this. I'll share this. I'll share this with the listeners. I'll share it with you. Is that I went in for a very routine mammogram. It was just time and turned out to be not so routine. And it was the radiologist who told me that news. I was still probably wearing that ridiculous gown, just sitting there waiting, not expecting this, not expecting to hear anything other than you can get dressed and go home. That was more than 20 years ago. I remember that conversation. It was very brief, but it had no context for me. It came out of the blue. Is that the kind of role that you have too? Or do you come along farther? Because then I had a lot of other things happen and a lot of other interventions. And then there was the biopsy and then there was the procedures and all that stuff. Then I got to know people on the team. Would you be the one, would a radiologist be the one generally to break that concerning news to a patient who's totally not expecting it?
Yes. And that's why I kind of pace that out. The last thing I want is for somebody to leave our center in tears that she's just very overwhelmed. But, interesting, if you put that warning shot out there and the patient can hear you, then when I call with those biopsy results, I often get, well, you thought it was, what are we going to do now? So they have more time to process that information. And interestingly, putting things into context, like breaking that bad news in context, patients actually do better.
Oh, really?
Yes. It's so interesting.
So when you look at that first image that you're looking at, you already have a sense. This is what you've been doing for a long time. You already have a sense of basically where this is going. You don't know the whole picture yet, but you know where it's going.
Mm-hmm.
And you have such a calm demeanor that, if you were the one who told it to me, it's like, oh, okay, I can breathe here. That would be my reaction. I know mine then. But what are other patients' common reactions to this?
So most women who have an abnormal screening, everybody knows the recall rate's about 10%. So they're kind of, oh yeah, my friend had that, or I had that 5 years ago. So for most people, that's not terrible.
Mm-hmm.
But when you're getting to that where you need a biopsy, and even more when you call them and let them know that they have cancer, that's going to be harder. So it's something that we work really hard to do well. And so most patients, they'll kind of, if they don't query, like when I say I'm pretty concerned about this spot, if they're like, all right, I'll come back for the biopsy, that's all they get that day. But some women really struggle with, sort of some maladaptive things, like they can be angry, kind of like shoot the messenger. They can refuse to come back.
Oh my goodness.
Yeah. And we have different ways to manage that. So I'd love to share a story. I had a patient. I had finished their ultrasound and was talking with her. This was definitely going to be a cancer, but a small one. And we went to the warning shot. She was like, well, how worried are you? And she was like, well, I'm not going to do anything. And this happens. It doesn't matter how smart they are. It's not an education thing. It's a lot of anxiety.
Right.
So I asked to have her husband come back and that we could talk about it together.
Mm-hmm.
So that's one thing that can help patients get through, even if they leave saying, I'm not going to do anything, because that spouse, significant other, son, daughter is going to keep saying like, I really think you should get that biopsy. But anyway, so we brought the husband back and I learned that their son, their only son, had passed away just within the last 6 months, I can't remember if it was lymphoma or leukemia.
Oh, he died of cancer.
Yes. And he was on chemo for a long time. It was really hard. There was not great quality of life. And that's what she was basing her decision on was, I'm not going to do chemo. I'm not going to do radiation. And so talking with her and her husband, I just said, number one, nobody's going to make you do anything you don't want to do. But if you get a biopsy, there are other ways that we could potentially treat this.
As you're telling me this story, and I want to hear the outcome of the story, but as you're telling me this, it sounds like you needed to understand her context. It's not just that the patient needs to understand the context. You needed to know where she was coming from.
That is such a great insight, Helen. That is absolutely the truth. No matter how a person responds, you need to understand where they're coming from. So anyway, she let us do the biopsy. It was the kind of cancer that can be treated like with tamoxifen or basically anti-estrogen therapies. And she had surgery, but she declined the radiation and she did great.
Sounds like it was a wonderful learning experience for you both in that way. You're talking about meeting somebody in person, but do you give this news over the phone too? Could it be either way, or is it mostly one or the other?
So the need for a biopsy, that's before the patient leaves the center.
So that's in person.
Yes. And then the bad news of cancer after the biopsy, we do that on the phone. A long time ago, we used to have people come in, but they knew what that meant.
Oh, okay.
Then they're very anxious coming into the center. So we do that over the phone now.
Do ever people these days get their results not from you directly, but they open their patient portal and there's no doctor explaining anything? Is that happening?
Yes. And it makes me very sad, quite honestly. News like that should be given to you from your physician. And I consider them that I'm their breast physician. So we do talk about that. After I finish a biopsy, I'll say, do you use my chart or whatever that program is?
Right.
And if they say yes, I say, well, you're going to see it before I do because I don't get the pop-up, but it's going to be in pathology language. So I'm going to talk with you after I see that result to review that and what our recommendations are. And I also, like, if it's kind of early, I'll kind of reiterate that, the biopsy might say that you have cancer, but don't panic. Remember, this is really small or, whatever that might show. so that there's kind of that second chance for a warning shot. So that's how I manage that.
That's interesting. You have to really do some education about you are going to get this before I see it. That's really interesting. That's probably something new that's been added to your practice in a number of years.
Yes.
So tell us more. You're a pro. You do this day in and day out about communicating with people. Often when you're involved, it's bad news. What would you like to share with all of us, wherever our sphere of influence is?
Just as in any sort of high stakes conversation, it's really important to stay calm and welcoming.
Calm and welcoming.
Yeah. Like I told you, sometimes women are angry. It's because they're just scared out of their wits. Don't take that personally. Don't tell them to go elsewhere, especially. Please don't ever do that.
What do you mean? How could you tell them to go elsewhere? Like go get a second opinion? Is that what you mean?
No, sometimes like providers will be like, well, if you don't like it, you can go see the doc across the street or something.
Oh my goodness.
I know, isn't that terrible?
And that's just responding to a patient who's upset?
I've heard about it, but obviously we would never do that.
And you're a woman, I'm a woman. Is it make these conversations any easier? I know men do get breast cancer, but it's rarer. Is the conversation easier in your opinion when you think it's woman to woman or not?
That's a really good question, Helen. I would think so, but I think it just depends a bit on the person. Because some women are like, I want a male doctor, or you know what I'm saying?
Okay. So putting a recap on this, and neither one of us can put this into another situation, but you talked about warning shots. I mean, you're the expert. You know how to read this. You know basically where this is going. I mean, you can be surprised too, but you can look at the image and you have a good sense of this one. So you talked about giving a warning shot if you think that it could be bad news and how to do that. You want to put it into context, it sounds like. So context, like, it may be cancer, but if it is, it's small or, whatever you're doing. It sounds as though you also need to hear the patient's context as well.
Yeah.
And that takes time to do that. That's not just a one-way conversation. And then you will have to do all of this and remain calm and welcoming. And that might be hard with people's extraordinary reactions to this one. Is that something that you would think that the rest of us can put into place when we have to share concerning news?
Absolutely. And, one thing I'll just add, Helen, is that, the women who come in with a lump and they know it's been growing for a while and they already know.
Oh, okay.
So you would think that those were like, how do you tell them that if it's bad? They already know.
Oh, okay.
Way behind in the back of their brain, but they know. Yeah, but I think those are really the steps, is that those things that you said, staying calm, empathetic, open-minded, non-judgmental, and being there for the patient.
Oh, thank you. What's the most rewarding part of what you do?
Oh, the best part is giving the good news when like a patient has a lump and I'm like, well, this is a cyst. It's just a little fluid sac. You're good to go. No risk of cancer. And I'll see you next year.
You're right.
That.
That is good news. And you're wonderful, Jennifer. Thank you for doing all you're doing. And I wish there were plenty of you around to be sharing good news, of course, but when it's bad news, doing it in a welcoming, empathetic way. Thank you, too, for so much for being a guest on Health Literacy Out Loud.
Well, thank you so much for inviting me. I really enjoyed the discussion.
As we just heard from Dr. Jennifer Harvey, health literacy is a factor in all the ways we communicate, even when the news is bad. But communicating clearly and effectively and empathetically is not always easy. For help clearly communicating your health message, please take a look at my book, Health Literacy from A to Z. Feel free to also explore my website, healthliteracy.com, or contact me directly at helen@healthliteracy.com. New Health Literacy Out Loud interviews come out the first of every month. You can get them all for free by subscribing at healthliteracyoutloud.com or wherever you get your podcasts. Please help spread the word about health literacy out loud. Together, let's tell the whole world why health literacy matters. Until next time, I'm Helen Osborne.